Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode includes content from an educational presentation from a dinner meeting titled Innovations in First-Line ART for Diverse Patients. This is part of the comprehensive program, Contemporary HIV Treatment and Prevention 2022. During this podcast, Dr. Princy Kumar from Georgetown University School of Medicine discusses ART selection in a newly diagnosed person with HIV who is obese with additional metabolic comorbidities. For more information about Dr. Kumar and this program, and to follow along with the slides, please visit the links in the show notes for this episode. Now let's get started and hear what Dr. Kumar has to say about this topic, starting with the case.
Now, this is a 47-year-old Black woman. She's newly diagnosed with HIV. She comes to see you. She has already her glucose level is a little bit elevated. She has hypertension. She's not been started on treatment. Her hepatitis B is pending. Look at her. Her CD4 count is 195. Her viral load is 250,000. She has no resistance mutations. You're already beginning to see her LFTs are a little bit elevated. And the reason her LFTs are a little bit elevated is she's a little bit already on the heavy side and she's beginning to develop some hepatic steatosis. Okay? So that's what they're saying there. So I want to know, she clearly is overweight. Oh, look at her BMI. You can see anything above 30 is considered obese. She's already a little bit older. She's underlying hypertension. But most importantly, she's overweight. And you're already beginning to see this. So a part of me says, I should follow the DHHS guidelines. And what is the DHHS guidelines? What should I give her? What is a preferred regimen for a newly diagnosed patient? An integrase inhibitor with either abacavir, TDF or TAP. That's a regimen. Or dolutegravir with 3-TC. That's the regimen. Okay? But here, if you go to think about it, there's a problem because now we know that integrase inhibitors are associated with weight gain. Period. So I'll show you just one couple of studies. This study came from South Africa. In South Africa, remember Africa said, how come Europe and America, they're using integrase inhibitors and we are still using efavirenz? No. We also want to start integrase inhibitors. But people from the University of South Africa said, wait a minute, let's do a study. Let's see what the differences is. So in South Africa, they looked at 3 different regimens. They looked at dolutegravir and efavirenz, because this efavirenz was the most widely prescribed regimen. And they looked at dolutegravir with FTC TAF or dolutegravir with FTC TDF. Okay? So dolutegravir with TAF or TDF. That's the difference between here and here was efavirenz, because this is what they used all the time. And where efficacy was concerned, they did the same. But what they did differently is they measured weight, because by the time the study was starting, they already realized that there was a problem with weight with the integrase inhibitor. So they brought in patients and they looked at weight in a systematic manner. And what they looked is, they looked at men and they looked at women. Right here, the red is the efavirenz FTC TDF. Here, in the light blue, is dolutegravir with FTC TDF. And in the dark blue here, is dolutegravir with FTC TAF. So you can see more weight gain for dolutegravir with FTC TAF than any other regimen. But the worst was women. Look at what they did to women. In women who took dolutegravir FTC TAF, look at the weight gain at the end of 96 weeks. 10 kilograms. Because this was done in South Africa, they did it in kilograms. You multiply it by 2.2, that is 22 pounds. In a period of 96, and the other thing is not only the weight gain, you're not seeing it plateau out. It's not stopping. You keep going and going and going and going. So this, and then there was also, you always, when you start ARV, you get weight gain because it's a return to health. That's healthy. All of us see patients, we put them on ARV and they gain weight, which is good because they're AIDS, you put them on a regimen, they're gaining weight. But what was abnormal is this very high weight gain that doesn't stop, that keeps going and going and going. Okay, so they said, this is one study. It's done in South Africa. Let's look at other data. And so Paul Sachs and his colleagues went and looked at 8 studies, retrospectively looked at 8 studies that had different integrase inhibitors that were there. And here again they looked at the integrase inhibitors compared to PIs and NNRTIs, and the red line is the integrase inhibitors. In 8 clinical trials that they brought together and they analyzed, the most weight gain is with integrase inhibitors. Below that came the PIs, and below that came the NNRTIs. That's why I said, if I see a lot of weight gain, that's when I change them off the integrase inhibitors. I don't know whether it will help, but that's what I do. If you look, then you'll say, among the integrase inhibitors, is there a difference? What I'm going to tell you is, we think both bictegravir and dolutegravir, both of them cause weight gain. So if you look at bictegravir, it's a red line. The dark green line is dolutegravir, and elbictegravir, povetacicept, which we really don't use a lot, is below. So in my mind, both dolutegravir and bictegravir causes weight gain. And if you look at the NNRTIs, ACT, people lost weight. The more seasoned clinicians will remember, people who took ACT got very nauseous. But if you look here, the most weight gain, the red line is all from TAF. That had the most amount of weight gain. Below that was abacavir, and then was TDF. It's looking at all of this weight data that the IAS USA guidelines went back and put TDF back because of all the weight gain that was seen from TAF. Okay. So here, I'm going to tell you again, among my take-home points here is weight gain appears to be more in those who start TAF than TDF, and more in people who take integrase inhibitors, whether it's bictegravir or dolutegravir, both of them cause weight gain. Both of them cause weight gain, then compared to an NNRTI or a PI. So it's dolutegravir, bictegravir with TAF that has the most amount of weight gain. Period. There's no other way to sugarcoat this. Okay? Now, not everybody gains weight. There are other determinants of weight gain. We think women are more likely to gain weight than men, and we think Black is more likely to gain weight than other groups. Okay? Also, we think not all the weight gain is bad. Some of the weight gain may be returned to good health. Okay. And so, what we don't know is what to do with people who gain weight. So, I see people that come to see me that are doing great. But I see people who have gained like 25 pounds after I started. They come to me and say, look at me, I look like a balloon right now. What is happening to me? And then I say, it's probably the drug. So we don't know whether stopping the integrase inhibitor, changing them to something like an NNRTI is the right. We don't know because we don't have the data. So all of us are we're waiting to get more data. But we cannot tell a patient, if I stop it and I change you, you're going to lose the weight. We don't know that information.
Thank you very much to Dr. Kumar, and thank you to our listeners for joining in. As a reminder to view the full Contemporary HIV Treatment and Prevention 2022 program on the Clinical Care Options website, and to access the slide set for innovations in first-line ART for diverse patients, click on the links in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you.